normal cardiac cycle and what happens, and we talk about the pressure volume loops in the cardiac cycle. We know that it have 5 phases. Now today we want to talk about this one. Now, of course, as you see here in the first, what are the sounds of the heart, and when this. Okay, now the sounds of the heart. As we know that S1 is the mitral and tricuspid valve closure. When the mitral and the tricuspid valve close, this is what will cause the S1 sound. And as we know, it's loudest at the apex of the heart, which is the mitral area. Now, of course, in the S1 closure closes before at the early systole. So we will see here the systole. This is here you have the systole. And the early systole, here you have the S1. At the beginning of the systole, you'll have S1 because it's the closure of the mitral and the tricuspid valve immediately before the systole begin. So here you have S1. This is here you can hear it. And after that comes the S2. And you know that the S2 is the aortic and pulmonary valve closure. When the aorta and the pulmonary valve close, that will give us the S2 sound. Now, S2 sound will close after the systole in the early diastole. So in the early diastole, we have S2, which is the closure of the aortic and the pulmonary valves. Now the closure, which is here, S2, in the early diastole, because right away after the systole finish, the aorta and the pulmonary close, and which is in the early diastole. You will have S2 at the end of the systole, and in the beginning of the diastole, you will have S2, the closure of the aorta and the pulmonary arteries. And as you know, aortic and pulmonary valve closure will give us S2, which is loudest at the left upper sternal border. We know that the left upper sternal border at the sternum, the left side of the sternum, you will have in the upper part of the left side of the sternum, you will have S2, which is the area of the pulmonary valve. Okay? You will see after a while the pulmonary area. Now, next one is S3. You have here S3. S3 happens in the early diastole during rapid ventricular filling. Now, S3, this is the sound of the rapid filling, the ventricular filling. So here you know that the aorta, the atria fill the ventricle. The rapid ventricular filling, the rapid phase of the ventricular filling, this is here what will cause the S3 sound. It's associated with increased filling pressures. Now, in the rapid filling in the diastole, we know that the ventricular filling happens in the diastole. So rapid ventricular filling, here you will have the S3 sound. Now, S3 sound, rapid ventricular filling in the diastole, which is increase the pressure, the filling pressure in the mitral regurgitation. And also in the heart failure. Why is sound increase in heart failure and in mitral regurgitation? Now we say that if for any cause increase in the atrial pressure, the atrial volume, so you will have more filling in the ventricle because the atria have more volume. So the atria have more volume, of course you will have more ventricular filling. And if you have more ventricular filling, you will have a sound louder, higher a sound. Now this more volume in the atria happens in two cases, like mitral regurgitation and the heart failure. In heart failure, there is increase in the volume in the heart, okay? Because of the less contraction, you have heart failure, increase in the volume of the heart, and this increase in the volume of the heart will lead to more or higher S3 because of the higher filling phase. And the same in the mitral regurgitation, because in the mitral regurgitation, the blood gets back to the right to the left atrium. Okay, in the mitral regurgitation during systole, here you have systole, contraction to the aorta, and also back to the left atrium. Okay, this will happen in the mitral regurgitation. So in the systole, the blood, instead of going to the aorta, it will go back to the right, to the left atrium. Okay, so in the atria you have more volume, so of course the ventricular filling will be increased, so the sound S3 sound will be increased, which is the rapid ventricular filling. Now, what is S4? And of course here the mitral regurgitation, and heart failure, but this sound S3 could be normal. There are cases that S3, increase in ventricular filling, will be normal. Like what? If you have a pregnant woman and children, because you know that the plasma volume in the pregnant woman will increase if you have more volume of the blood and the plasma, so increase in the ventricular filling. If you have increase in the ventricular filling, of course you will have higher S3. And the same as in the children. You know that the percentage of water in the children is higher than us, the adults. So that's why in children you will have more volume, and of course if you have more volume, more ventricular filling, and this is what will cause higher S3 sound. Now what about S4? S4 here is in the late diastole, which is the atrial kick. In the late diastole, there is a little amount in the late diastole. We know that this is here before the start or before the beginning of systole. Before the beginning of systole, you will have to end the amount of the blood in the atria. So at the end of the diastole, after the filling of the ventricles, there is still a little amount in the atrium. Okay, there's still a little amount in the atrium, and this amount need to be pushed out of the right atrium or any atrium of them to close the mitral valve. So because before closing the valves, the mitral and tricuspid, you need to push all the blood in the atria, and this, to make more force to push this blood, you need to contract the atria. The contraction of the atria at the contraction of the atria at late diastole, at the end of the diastole here, and before the beginning of systole, you have atrial contraction. Now, atrial contraction is represented by S4. As you see here, the contraction, the atrial systole, which is the contraction of the atria, is the same as the S sound. The contraction of the atria will cause S4 sound. Okay? So in the late diastole, the atrial kick, which is the systole, best heard on the apex. So you have S1, S3, and S4 is best heard at the apex of the heart. And you will see where is the apex after a few seconds. Now here, the S4 is best heard at the apex of the heart, and when the patient is left lateral decubitus position، لما يكون نايم على جنبه اليسار، the left lateral decubitus position. At the apex, in the left lateral decubitus position, this is the best way to hear the atrial systole, which is S4 sound. Now, high atrial pressure, if you have high atrial pressure associated with ventricular hypertrophy, if you have ventricular hypertrophy, the ventricles have much, but it is more stiff. So imagine that there is a ventricular hypertrophy, the muscles and the wall of the ventricles are huge, and you have here a stiff ventricular walls, so the atria need more force, need more force of contraction to push the blood to this stiff ventricular wall. So you will have the S4 will be higher, which is the atrial contraction, because it needs to push the blood against this stiff ventricular wall. Now let's see, you have the second thing here, which is the jugular venous pulse. The jugular venous pulse, as you can see, this is the jugular, wait a minute. Now, as you can see, here is the jugular vein. We are talking about this one, jugular vein, which is here. This one, the internal jugular vein. Now, we have jugular pulses. The jugular venous pulse is, of course, will represent, it's a vein. Yes, it will represent the right side of the heart, the right atrium, and of course, tricuspid is here, tricuspid valve, and here you have the left atrium, the right, ventricle. Okay, so the right atrium, the tricuspid, and the right ventricle. Now, what happens? Now we are talking about this part of the heart, the right side of the heart, because we are talking about the venous pressure, the venous pulse, the jugular venous pulse. Now let's see here. You have A wave from the atrial contraction. So we talk about the atrial contraction here, which is the same as S4, if you remember. The atrial contraction was as the same as S4. And here you have the A wave. A wave, it's a wave. Okay, a wave. So A wave is from the atrial contraction. So you have the A wave in the jugular pulse. It is absent if you have atrial fibrillation, because in atrial fibrillation you don't have contraction of the atria. No contraction of the atria, so no atrial systole, so no S4 or A wave. Okay? You don't have any sign of atrial systole in the atrial fibrillation. Now, what happens next? Of course, after the atria get contracted, the ventricle, the right ventricle, now we are talking about the right side. So the right ventricle will contract after the right atrium contract. So the right atrium, which is the A, contract. Now we have another contraction here for the right ventricle, which is the C wave. Now the C wave is the right ventricular contraction. The contraction of the right ventricle is represented here as the C wave. Closed tricuspid valve, when in this here, when the contraction of the right ventricle happens, so the closed tricuspid valve will bulge to the right atrium. Okay, so we have the ventricular contraction. This contraction of the ventricle will push out this tricuspid valve, the closed tricuspid valve, because we are in systole. We are now in systole, so of course the tricuspid is closed. This closed tricuspid will bulge into the right atrium. Now, what happens? What is next? Next, you will have the X descent, which is the atrial relaxation. Of course, you know that here you have the atrial contraction. Now the atria need to relax. The atrial relaxation, it's a descent, decrease in the pressure. That's why it's a descent. Decrease in the pulse, decrease in the jugular pulse, so it's a descent. Here you have a descent, which is the X wave. X wave is the descent of which is represent the atrial relaxation. Relax. The X wave. That's why it's X wave. From relax, okay? So the atrial relaxation is represented here in the jugular pulses as X descent. Decrease in the pressure. And downward displacement of the closed tricuspid valve during ventricular contraction, absent in tricuspid regurgitation. Now, what does this mean? Now, we say that the X here, the X descent, is the same as the atrial relaxation. Okay, so X here is the relaxation of the atria. Now, if you have a tricuspid regurgitation, here you have this one here, the right ventricle, and here you have the right atrium. In the tricuspid regurgitation, the blood flow back to the right atrium through the tricuspid valve during the systole, okay? Here you have the systole, the right ventricle should push the blood to the pulmonary artery, but instead of going to the pulmonary artery, it will go also to right atrium because this is open, the valve is open and it's abnormal, okay? It is abnormal, so it is open. This happens at the right and the tricuspid regurgitation. So you have the right atrium is still fill or have a blood in it. So the right atrium is still have a blood because we have regurgitation or the blood come back to the right atrium. So there is no relaxation of the atria. In this case, if they have the tricuspid regurgitation, we will don't have this X descent. There's no relaxation. So this X descent is absent if we have mitral or tricuspid regurgitation. Now, what is next? Now the next, after the atrial relaxation, you will have the V wave, which is the filling of the right atrium. Now the filling of the right atrium, this is what will cause the V wave. The filling of the right atrium is the isovolumetric relaxation. When all the valves close, the tricuspid is closed, and the pulmonary valve close. This we call it the isovolumetric relaxation. Okay, all the valves close in the heart, but here the right atrium is still filled with the blood. Now is the time to fill the right atrium, okay? How we fill the right atrium? By the superior and inferior vena cava, of course. So now the superior and inferior vena cava fill the right atrium with the blood. And both or all the valves is closed. The pulmonary, the mitral, the aortic, and the tricuspid, all the valves is closed in the isovolumetric relaxation. Now, in this case, when the right atrium increases the pressure and the volume because of the superior and inferior vena cava fill the blood, this is the V wave, okay, from filling, okay, filling or filling. So you have filling of the right atrium, we call it the V wave. And it's, of course, right before the rapid ventricular filling. Before the ventricular filling, the atria itself need to be filled. And this is what happened in the V wave. Now let's move to the Y descent here. Now the Y descent, which is the end, the last one of the jugular pulses, the jugular venous pulse of the right side of the heart, the right atrium and the right ventricle. Now in the Y descent, the right atrium emptying into the right ventricle. Now as we know here, now the atria is filled in the V wave. The atria filled with blood from the superior and inferior vena cava. Now, what is the next step will be, of course? Of course, it will be the filling of the right ventricle, yes? Now, the right atrium is filled of a blood, it's filled with blood. Now, what's the next step? To push this blood to the right ventricle. So this is what represents the Y wave. Y descent. Why it is descent? Because the decrease in the volume of the right atrium. Decrease in the volume of the right atrium will cause this descent because it is the same as rapid ventricular filling. Now we are full the right ventricle with blood, so the right atrium volume decrease. And because the right atrium decrease, of course you will have descent, okay? So now this is the end of the right or the jugular venous pulses, and also we talk about the sounds of the heart. Now let's move to the next one. Now here we are talking about the splitting of the heart sounds. Now splitting of the heart sounds, of course it will be, we have normal splitting, which is normal people have this normal splitting. What is the normal splitting? I want you to look here carefully. In the expiration, you don't have a gap between A2 and B2. You don't have a gap. Yes, while in inspiration, when you take the breath in your chest, you have gap between A2 and B2. Now, first of all, what happens? What is A2 and B2? We know that we have S1, which is the closure of the mitral and the tricuspid valves. Now, when we talk about the A2 and B2, is of course will be the S2, yes? So what we say about the S2 is the closure of the aortic valve and the pulmonary valve. So aortic valve and the pulmonary valve get closed, this will cause S2. Now this is what we talk about. Here we have the aortic valve. When it's closed, we will have the sound, the S2 sound. And the B2, when it's closed, we will have the S2 sound. Now there is a normal splitting. Normal in the normal people, we will have splits only in inspiration. So normally we have only in inspiration we have splitting, okay? Splitting انفصال between the A component, the aortic closure, and the pulmonary closure. We have normal splitting between these two. Only in inspiration, when I take the breath in. When I take the breath out, which is expiration, there's no gap between them. Okay, no gap. So what this mean, no gap? This means that the aorta and the pulmonary valve close together. Okay, they close in the same time. They both close in the same time. Okay, get closed in the same time. This is what we mean when we don't have a gap. If we have a gap, this means that like in this case here, the aorta, as in this case, the aorta closed first. You have A2 before B2. In inspiration, the aorta close before the aortic valve, okay? The aortic valve closed before the pulmonary valve. So A2 closed before the B2. This is what we mean by the splitting in the inspiration, because one of the valves close before the other. Now we want to know now, why does this happen? Why does this happen? Look here, what happens in the normal, why we have splitting in the inspiration while we don't have any gap between the expiration? The reason is simple here. If you look here, inspiration will cause a drop in the intrathoracic pressure. There's a drop in the intrathoracic pressure, so you will have more venous return. More blood comes to the heart, to the right side of the heart, to the right atrium, and to the right ventricle. Okay, because you have a decrease in the intrathoracic pressure, and this decrease in the intrathoracic pressure will cause that more blood will come to the right side of the heart. And when we say more blood comes to the right side of the heart, more volume or more blood in the right atrium, so more blood will go to the right ventricle, and so more blood will go through the pulmonary valve. So of course, in inspiration, because in inspiration all of that happen when we take a breath in, the intrathoracic pressure decrease, the blood that comes to the right ventricle will increase, the right atrium increase in the volume, the right ventricle increase in the volume, the blood that go out through the pulmonary valve will increase in volume, thus the closure of this pulmonary valve will be delayed, okay? It will not close as the aortic valve, it will be delayed. It will close after the aortic valve because in the inspiration, the right ventricle have more volume, so it will take more time to empty this right ventricle through the pulmonary valve to the pulmonary artery. It will take more time to get this right ventricle to be empty. It will take more time. Now let us move and talk about, now here what you have. As we say, in inspiration you have a drop, and in inspiration you have a drop in intrathoracic pressure, and thus you will have increase in the venous return, more blood comes to the heart, the right ventricular filling will be more, increase in the filling of the right ventricle, increase in the filling of the right ventricle, this means increase in the volume. Okay, increase in the volume in the right ventricle. And of course, if you have right ventricle filling increase, this will lead to increase the right ventricular stroke volume, which is the amount of blood is ejected to the pulmonary artery in one beat. So the stroke volume will increase, and if the volume and the stroke volume increase, this will mean more right ventricular ejection time. It will take more time, and this will lead to delayed closure of the pulmonary valve. If we have delayed the closure of the pulmonary valve, you will have decrease in the pulmonary impedance.